Hello everybody. Today we are going to discuss about right ventricular dysfunction. There are some terms associated with the right ventricular dysfunction. They are often used interchangeably but in reality signify the different disease process. Right heart failure and the right heart failure syndrome means the dysfunction of the right heart system, starting from the systemic vein till the pulmonary capillary, which result into the inadequate flow to the pulmonary vessels and signs of the congestion into systemic vein at rest or with exercise. Right ventricular dysfunction is the systolic dysfunction of the right ventricle, which results into the right heart failure syndrome. Acute cor pulmonale is the right ventricular dysfunction caused due to increase in the afterload of the right ventricle. All this syndrome may occur acutely or develop over a year as a chronic disease. Now about physiology and pathology. Compared to the left ventricle, right ventricle remains a thin walled chamber and it has three anatomical parts. The inlet starting with the tricuspid valve, which also include the chordae tendineae, papillary muscles, the trabecular apex, and the outlet or conus. Its cross section can look like sickle from one view and a triangular from the another. RV contraction in the systole occurs by bellow-like movement of the free wall as well as by its longitudinal shortening. Blood supply to the RV occurs through its own coronary artery. In contrast to the left ventricle, which receives its perfusion only during diastole, the perfusion of the right ventricle occurs both in systole and diastole. For this reason, a fall in the systolic blood pressure may seriously compromise RV perfusion and may add its dysfunction. In case of primary damage or any shock to this coronary artery, the coronary perfusion of RV drops, causing ischemia and worsening of the RV systolic function. As RV is tuned to eject into low pressure bed, it is capable of handling volume overload and the preload better than the pressure overload or afterload. It has two types of the afterload. The first being stationary, which is made mostly by pulmonary vascular resistance. The second type is dynamic or pulsatile, which depends on the stiffness of pulmonary artery, total pulmonary capacitance, and the reflected waves. Stationary afterload increase in the acute respiratory distress syndrome and is better handled by the right ventricle. The dynamic afterload increases in the pulmonary embolism and in response to the LA pressure. Initially, increase in the afterload is handled by a process called as homeometric compensation, where ventricular size remains normal. Later, after the pulmonary artery systolic pressure increases beyond 30 mmHg, the RV starts to dilate and this increase in the stretch of its wall, which in turn augment the contraction. This is the heterometric compensation. RV starts failing when the pulmonary artery systolic pressure crosses 40 mmHg acutely. The effectiveness of RV contractility in compensating the increase in afterload is maintained by a phenomenon called right ventricular pulmonary arterial coupling. This is measured by the ratio called RV end systolic elastance and the pulmonary artery elastance. If this ratio falls below 1.5, the compensation starts failing, which is called uncoupling of RV and the PA. The tricuspid valve is also a unique structure as it increases in the diameter in response to the RV dilatation. This causes tricuspid regurgitation. This regurgitation protects the RV from getting further dilated, but subsequently causes rise in RA pressure and ultimately systemic congestion. There is another phenomenon called ventricular interdependence. The left and the right ventricle share the interventricular septum, a portion of the myocardium and the limited space enclosed by the pericardium. The afterload of the RV pushes the interventricular septum more towards the LV. This occurs during diastole when LV pressure remains low. This causes LV filling defect, which in turn affects the cardiac output. A drop in the cardiac output, sometimes drop in the systolic blood pressure, compromise RV perfusion by the coronary artery. This further causes RV dysfunction. Low cardiac output state trigger the renin-angiotensin system and causes the fluid retention. Now about etiology and epidemiology of the acute right ventricular dysfunction. Few common etiologies of acute right ventricular dysfunction are listed below. Secondary to the acute LV failure, acute respiratory distress syndrome, pulmonary embolism, acute exacerbation of COPD, right ventricular infarct, and arrhythmia. Cardiomyopathy, pericardial tamponade, sepsis, worsening of chronic pulmonary artery hypertension, valvular heart disease, congenital heart disease, and myocarditis. Post cardiac surgery, post LV assist devices, sickle cell crisis, post cardiopulmonary resuscitation. The most common cause of RV dysfunction is pulmonary hypertension. Sudden worsening of the chronic pH due to infection or arrhythmia, which can precipitate acute RV dysfunction. Even mild increase in pulmonary arterial systolic pressure may precipitate acute RV dysfunction in conditions such as ARDS, septic shock, and acute left ventricular failure. All these conditions are associated with negative inotropic effect. The mechanical ventilation with high tidal volume and high airway pressure also precipitates pulmonary arterial constriction, increases pulmonary artery systolic pressure, and precipitates or worsen acute RV dysfunction. RV, if already deformed like chronic PH and connective tissue disorder, is more likely to fail under stress. Almost 25% of all ARDS patients develop acute pulmonary edema. Acute cor pulmonale, even with strict lung protective ventilation from the large cohort of 700 patients, where tidal volume are strictly maintained below 6 ml per kg, plateau pressure below 30 centimeter of water, the incidence was 22%. About one third of patients with pulmonary embolism develop some amount of RV dysfunction, and 4.5% of patients of PE go into shock. One third of the patient with acute inferior wall infarction have associated RV myocardial infarction. Many of the patients with septic shock, exacerbation of COPD also have associated RV dysfunction and right heart failure syndrome. Post-cardiac arrest patients who have been successfully resuscitated showed RV dysfunction in 90% of cases. In all cases, associated RV dysfunction worsened the outcome. Now about diagnosis of right ventricular dysfunction and right ventricular failure. The tests for measuring right dysfunction and failure are clinical, biochemical, ECG, echocardiography, right heart pressure measurement, MRI of the heart. So about clinical signs, the clinical signs of acute right heart failure syndrome are quite different from those of chronic right heart failure syndrome. Unless the acute failure occurs in patient with the chronic heart failure syndrome. The hallmark of acute right heart failure is poor cardiac output with symptoms and signs of tissue hypoperfusion. The patient complains of shortness of breath, mostly due to tissue hypoxia and acidosis. The patient mostly present with tachycardia, fall in blood pressure, cold clammy extremity, peripheral cyanosis, oliguria, and confusion. Typical finding of pulmonary edema such as hypoxemia, central cyanosis, basal crepitation in the chest are not feature of acute right heart failure syndrome. Raised jugular venous pressure, hepatomegaly, ascites, pleural effusion may be present in patients with chronic right ventricular dysfunction who had suffered acute decompensation of RV function. About biochemical feature, biochemical abnormalities of acute right ventricular syndrome are raised natriuretic peptide like beta type natriuretic peptide, pro beta type natriuretic peptide, raised troponin level in RV infarction and pulmonary embolism. Other than two raised blood urea nitrogen and creatinine level, raised liver enzyme due to congestive hepatopathy, raised serum lactate may be present. About ECG findings are less obvious than the chronic heart failure. Instead of right axis deviation of the QRS complex, R by S wave ratio is more than 1. R wave amplitude of more than 0.5 in lead V1. The typical ECG finding of chronic RVD and the signs of acute RVD are as follows. QR pattern in lead V1, prominent S in lead 1, along with Q wave and inverted T wave in lead 3. S1Q3T3 syndrome, a typical but rare finding in patients with large P. P wave larger than 2.5 in the leads 2 and 3 and AV. In case of RV infarction, there is ST segment elevation in lead V4R. About 2D echo qualitative assessment. This has been one of the earliest and easiest way of assessment. The echocardiographer assesses the RV performance by visual impression. The results are highly operator dependent, devoid of any quantification, and at best at an approximation. RV size, RV free wall thickness in the systole of more than 5 mm signifies the RV hypertrophy. Usually, LV end diastolic diameter to the RV end diastolic diameter ratio is greater than 1.3. A ratio of less than 1 means RV dilatation. RV basal diameter in 4-chamber view of 41 mm or above is also signifies the same. Now about McConnell sign. This is typical but not so common sign of acute increase in RV afterload. There is akinesia of the mid-free wall of the RV but normal wall motion at apical area. Fractional area short. Trace RV area in 4-chamber view during systole and diastole. Dividing the difference between diastole and systolic area by the diastolic area is the fractional area short. Value less than 35% means RV systolic dysfunction. Now about tricuspid annular plane systolic excursion. An M mode measurement across the lateral part of the tricuspid annulus is taken. The excursion when less than 17 mm is abnormal. TAPSE may not be very accurate in patient with pericardiac tone. S-wave measurement at tricuspid annulus by the tissue Doppler. Measurement of the tissue Doppler of the longitudinal velocity of free lateral wall of RV is called S. The sample volume is placed at the base of RV wall dysfunction or adjacent tricuspid valve annulus. A velocity of the 0.095 m per second is taken as RV dysfunction. This value correlates well with the RV ejection fraction calculated by Emma. Now, LV eccentric index. It is a ratio of end diastolic diameter of LV parallel to the interventricular septum. The diameter perpendicular to the septum. Both the measurements are taken in the parasternal short axis view at the end of systole. If this value is more than 1, then that signifies pulmonary artery hypertension. Now, the next parameter is spectral tracking to calculate RV wall strain. Software can measure the movement of grayscale pixel to each other. This measures the degree of deformation. It is the dimensionless number. More negative it is, more is deformation. Normal values are more than -20 to -20. This is the surrogate for RV systolic function. Manual measurement of RV free wall length in the end systole and end diastole can be used, and its spectral tracking is not available. 3D echocardiography is used to calculate RV systolic function. Even spectral tracking can be done in the 3D mode. This method have not been well studied in acute right ventricular failure. Now, echo in specific situation. Picking up RV also LV wall motion abnormalities after myocardial infarction is an important measure. Flattening of the interventricular septum occurs during any acute rise in the RV afterload, like in case of large P. This is called DC. TR jets may be used to calculate pulmonary artery systolic pressure. Transesophageal echocardiography is helpful in the cases of congenital heart disease. CT and MRI scan. CT pulmonary angiogram is the standard test of P. Cardiac magnetic resonance imaging, native T1 image, and T2 weighted images. Contrast images are excellent tool to assess both global function of RV and regional wall motion defects. Although the use of MR in acute right heart failure patient has been limited, mostly due to difficulty in doing it in acute patient and unavailability. Pulmonary artery catheterization. Pulmonary artery catheterization has been a very useful tool in in directly measuring various intracardiac pressure and measuring cardiac output. Though it has somewhat fallen out of favor, it still remains the gold standard for measuring the right heart pressure. It can measure the central venous pressure, RV pressure, pulmonary artery pressure, the cardiac output, pulmonary capillary wedge pressure, which is surrogate for left atrial pressure. The typical finding of right ventricular dysfunction and right heart failure syndrome are low cardiac output. Now about biomarkers, so biochemical marker, the brain natriuretic peptide and terminal pro brain natriuretic peptide, cardiac troponin detect heart failure and myocardial injury. They may provide additional valuable information at time. They are used both for diagnosis and for prognosis. Now about management of acute RVD and acute right heart failure syndrome. The basic tenets of acute right RV dysfunction and the right heart failure syndrome are optimizing the RV preload and afterload, correcting the factors causing RV dysfunction, augmenting RV contractility and correcting arrhythmia. Echocardiogram is the most important tool in guiding treatment. However, most invasive monitoring like pulmonary arterial catheter may be needed at times. Now managing preload. RV function is highly sensitive to both abnormally high and abnormally low preload. Preload can be reduced in situations due to various reasons. For example, hypovolemia, third spacing fluid in septic shock, positive pressure ventilation interfering with venous return, sedatives and analgesics during blunting of sympathetic tone of systemic vein and again interfering with venous return. The assessment of the preload can be done clinically by checking jugular venous pressure, looking for peripheral edema. Maintaining CVP at 8 to 12 mmHg is reasonably good strategy to maintain proper preload. CVP monitoring, echocardiogram, and in difficult cases, pulmonary artery catheter remain important tool to assess preload. A finding of significant pulse pressure and stroke volume variation signifies preload responsiveness, but no effective improvement after fluid infusion may suggest a right heart failure syndrome. When preload is low, careful loading with the crystalloid would increase the cardiac output. Right ventricle poorly handles excessive preload when afterload is also high. Hence, treating physician should be more careful about volume overload in right ventricular failure with increased afterload such as acute respiratory distress syndrome or P. If preload is high, it interferes with RV function and also later with LV function. As mentioned above, increased preload can be detrimental as low preload. Hence, increased preload could be corrected. This is even more important in cases where afterload is also reached. When diuresis fails, hemodialysis is needed to reduce the excess preload. Usually, loop diuretics such as furosemide are used with thiazide-like metalazone added in cases of inadequate response. Even in hypotensive patient, diuresis may be tried after stabilizing the blood pressure with vasopressin. Successful diuresis may paradoxically correct the hypotension. Now managing the after. Afterload is increased in many patients with acute right heart failure syndrome. This may be due to worsening of pre-existing pulmonary artery hypertension, secondary to the left ventricular failure, pulmonary embolism, acute respiratory distress syndrome, pulmonary artery constriction due to hypoxemia, alveolar and pulmonary artery hypoxia, hypercapnia, and acidosis. But both too high and too low tidal volume, when patient is ventilated, will increase pulmonary arterial resistance. Pulmonary vascular resistance remain low when lung volume is near functional residual capacity. Mediators such as serotonin and interleukin 6 in septic patients and decrease for production of nitric oxide in sepsis. The primary measure to reduce afterload are by correcting precipitating cause. Correction of alveolar and pulmonary artery hypoxia should be that is maintain the SO2 of 92% or above and correcting hypercapnia as well. It should be noted that all the above mentioned measure may be in contrary to the usual management of ARDS. Primary pulmonary vasodilator are the first line drug to reduce RV after. They can cause the simultaneous systemic vasodilatation and hypotension. They also may increase the pulmonary flow in poorly ventilated lung area, causing ventilation perfusion mismatch. Nitric oxide has also been used in ARDS patients. It reduces pulmonary vascular resistance, increases RV output. It also works in well ventilated areas, thereby improving ventilation perfusion ratio but does not change the outcome. Inhaled mendrinone has surgery patient. It reduces the pulmonary vascular resistance, increase RV output without causing systemic hypotension. However, it did not change the outcome. Prostacyclin analog increases cardiac output and decreases the PV. They act via cyclic adenosine monophosphate pathway. Inhaled epoprostenone have been used in patients after cardiac surgery who develop acute right heart failure syndrome. Other pulmonary vasodilators such as phosphodiesterase 5 inhibitor, endothelin receptor blocker, soluble guanylate cyclase stimulator, riociguat, and the calcium channel blocker are not recommended in acute right heart failure. Managing RV dysfunction. As discussed above, RV contractility may be acutely compromised due to RV infarction, poor RV perfusion due to right heart failure syndrome and systemic hypotension, sepsis, and arrhythmia. Supporting poorly contracting RV requires correction of precipitating cause. For example, correction of atrial fibrillation and inotropic support. Inotropic support in turn can be pharmacological as well as mechanical. Now, pharmacological inotropic support. The ideal inotrope in the case of RV dysfunction will augment RV contraction and will not cause an increase in RV oxygen demand and will not cause the pulmonary vascular resistance. Or even better, will decrease the pulmonary vascular resistance. Often the dysfunction of RV will also require vasopressor to maintain systemic blood pressure. This vasopressor preferably should not increase pulmonary vascular resistance. Now we'll discuss few inotropes and vasopressor which are used in acute right heart failure syndrome. So first is dobutamine. It is selective beta-1 agonist. It is positive inotropic agent, augmenting the contraction of ventricle. It also causes systemic vasodilatation at higher doses via B2 receptor. This effect may precipitate hypotension, cause RV and PA coupling. Then dopamine, it is another sympathomimetic drug which act through different receptors, namely dopaminergic B1 and B2 and alpha, depending on the dose. It acts as a both inotrope and vasopressor, and it does not increase pulmonary arterial resistance up to dose of 16 microgram per kg per minute, but will increase RV afterload above that dose. Norepinephrine, it is a strong alpha agonist, act as vasopressor, but also has some beta activity and thus may augment the output of both ventricles. In patients with the septic shock, norepinephrine was found to improve RV perfusion by raising systemic artery pressure, but also increases RV after. Now about vasopressin, it acts by a V1 receptor to increase systemic blood pressure. It is used along with norepinephrine to combat hypotension and shock. It helps in RV and PA coupling by reducing PVR by nitric oxide mediated pathway. This beneficial effect is lost at a dose of more than 0.03 unit per minute. Epinephrine, it acts via both alpha and beta receptor. It acts both as vasopressor and inotrope, and it also increases PV. Mendrinone, it acts through selective phosphodiesterase 3 inhibition. It augments biventricular contraction, decreases PVR, causes less tachycardia than dobutamine. It may precipitate hypotension like dobutamine does. It is used extensively in patients undergoing cardiac surgery, including heart transplant. About levosimendan, it is a novel calcium sensitizer. It is also inodilator like dobutamine and midinone. That is, it augments the biventricular contraction with systemic vasodilation. It increases both systolic and diastolic function of RV without increasing an oxygen demand. It reduces PVR, improves ARIA-PA coupling. Compared to dobutamine, it increases RV perfusion, improves GFR, causes less increase in myocardial oxygen demand. In the nutshell, acute right heart failure syndrome will need inotropic support along with optimization of the preload and after. It will also require vasopressor to maintain systemic blood pressure when patient is hypotensive. In our unit, we prefer levosimendan as a inotrope along with norepinephrine with or without vasopressin as a vasopressor when needed. Drugs such as beta blocker are used to control arrhythmias and tachycardia. Amiodarone and digoxin may also be used to treat arrhythmias like atrial fibrillation. About mechanical assistance device and the extracorporeal support. In many type of acute right heart failure syndrome, this type of support may be used when pharmacological therapy fails to achieve treatment goal. RV failure may have better outcome than the LV failure, making explanation of the devices possible. Mechanical RV assist device may be implanted percutaneously or surgically. Then extracorporeal membrane oxygen may be again of venovenous and venoarterial type depending on the situation. Thank you guys.